Morning. We'd like to call the Pension Health Benefits Committee meeting to order. First order of business would be to call the roll, please.
Rob Fechner.
Good morning.
Ramon Rubalca.
Here.
Margaret Brown.
Excused.
Henry Jones.
Here.
David Miller.
Here.
Arena Ortega. Here. Mona Pascal Rogers. Here. Teresa Taylor. Here. Karen Greenross for Betty Yee.
Here.
Thank you. Please also show Ms. Taylor, Ms. Oliveras, Mr. Ruffino, Ms. Middleton, and Mr. Perez joining the committee today. Oh, I'm sorry. I thought you said you weren't earlier. I missed that. Next order of business, item 2, is the approval of the timed agenda. What's the pleasure of the committee? Moved by Miller, seconded? Second by Taylor. Any discussion on the motion? Seeing none, all in favor say aye. Opposed, no. Motion carries. Before we move on to item 3, I'm going to take a moment to honor the service of Donna Lum. Donna is our Deputy Executive Officer over our customer services and our support teams. Donna will be retiring next week after 21 years here at CalPERS and another 15 with the state of California. Throughout her career, she put her passion for our mission here into action as she led her teams to improve customer service. Donna joined us early in 1999, about 3 months after me. So she's about the only one left here that was here when I started. And she certainly was here to help us begin preparation for Y2K, if any of you remember those days. She had a strong vision for how technology could enhance our services and was deeply involved in the creation of the CalPERS system. In 2012, Donna joined the executive team, and I've seen many customer service enhancements throughout her leadership. Here are just a few. Our customer contact center receives over 1 million calls each year with a 94% satisfaction rating. Our employer response team handles nearly 1,000 critical time-sensitive issues each year, usually within 1 day, consistently exceeding a 90% satisfaction rating. Donna created the employer leadership dialogues, which are held throughout the state to listen to employer needs and facilitate their communication. And finally, there's been an increasing compliance with payroll reporting, with 99% of employers submitting reports on time. Donna, we're all very grateful for your dedication to our CalPERS team, to the members of this system, and to this board. So on behalf of us, enjoy your retirement. You and Alan have a great time, and we certainly will always remember the work you've done here. Thank you very much. That we'll move to agenda item 3, the executive report. Mr. Moulds, Ms. Lum.
Good morning, Mr. Chair. Donna Lum, CalPERS team member. First of all, I'd also like to take a moment of personal privilege and thank you, Mr. Chair, for the kind words that you shared. It seems like it's not been so long ago where I was the liaison to the Benefit Program and Administration Committee, also known as BPAC, and certainly have known you and Mr. Jones the longest with regards to the work that I've done on the board. But it's been my pleasure to have worked with this committee specifically on the many legislative and regulatory implementations that we've gone through over the many years that I've been involved with the committee. In addition to that, we've worked on a lot of strategic and policy issues, many that have really shaped the way that we deliver our services, our customer services to our members and our employers. And for that, I do want to thank all of you for the support that you've given, not only to the customer service teams, but to all CalPERS team members. It's really been an honor and a pleasure to have worked with you all and to be able to end my public service career here at CalPERS. It's been, as I've said several times in several celebrations that I've had over the last couple weeks, the most rewarding part of my career, being here at CalPERS and fulfilling and serving on the mission that is extremely important for our members, our beneficiaries, and our survivors. So thank you all.
Thank you.
With that, I do have one item to report out to close this calendar year, and that is we are preparing for the 2020 CalPERS Benefit Education events. Our first event is going to be held at Rohnert Park on January 10th and 11th, and this is expected to be a fairly large event. The last time we were in Rohnert Park, it was 2016, and we had nearly 1,100 attendees. Yesterday, we sent out emails to nearly 45,000 members in the surrounding counties, including Contra Costa, Marin, Mendocino, Napa, and Sonoma, encouraging members who are either nearing retirement or mid-career to come and join us at this CB. At the CBs, we do surveys and we take a lot of member input on what we can do to improve the delivery of the presentations and the education that we provide. And one of the things that we received feedback on that we are implementing for the 2020 CBs is what we call a new QR code capability. And so members that are attending the CB will have the option to easily scan a QR code, and the materials that are available on the website will be easily available to them on their mobile devices. And so that does help to reduce the paper plan that we have, initiative that we have, but it also gives direct access to the attendees to the materials. In addition to that, we have developed what we're calling learning guides for the CBs, and these are very concise references that will again help our attendees to retain the information that they're receiving. And then lastly, the additional input that we received from members is that we do have a CB checklist available on the website, and that's to help attendees plan well in advance which of the presentations they want to attend, and that also helps us to plan for capacity needs for the locations that we are hosting at. The Rohnert Park CB will then be followed by San Luis Obispo on February 7th and 8th, and the full calendar of the 2020 CBs is located on the CalPERS website. Mr. Chair, that concludes my remarks, and I'm happy to answer any questions you may have.
Thank you very much. None for your lucky day.
Thank you.
Mr. Moulds.
Good morning, Mr. Chair, members of the committee, Don Moulds, CalPERS team. First, I have 3 items for my remarks today. First, I want to share with the committee that our annual health plan member survey will be kicking off January 7th. The survey assesses members' experience with their health plans during the 2019 health plan year. The results will help us measure member satisfaction with their health plans, specific outcomes and trends, as well as quality and access to health care, including in rural areas. This year, we also added 6 new validated mental health questions to help us improve the quality of mental health services for our members. The survey will run through March 3rd. Second, I want to let the committee know that last week we sent a letter to Cottage Health after learning that they were at an impasse in their contract extension negotiations with Anthem. Cottage runs 3 hospitals in Santa Barbara. If Cottage and Anthem are unable to reach an agreement by the end of the year, members living in the area who have our PPO plans or Anthem traditional HMO will no longer have in-network access to the 3 Santa Barbara hospitals. The next closest hospital is roughly 40 miles away. The situation not only affects our existing members, but we are bringing 2 new public agencies in Santa Barbara on board effective January 1st, the City of Santa Barbara and the Santa Barbara Housing Authority, so this would impact them as well. We're closely monitoring the situation. I've personally spoken to both Anthem and Cottage multiple times over the last few days, and while this is a negotiation between 2 private parties, we're pressing both sides to resolve the dispute. Anthem has sent letters to potentially impacted members, and we've communicated internally with the call center and stakeholders in the area. We'll keep everyone apprised as we know more. And lastly, our agenda today continues our important discussion of how to improve mental health care for our members. As you'll recall, last month we had a discussion with Kaiser. Today, Dr. Logan will facilitate the discussion with our 3 other large health plans, Anthem, Blue Shield of California, and UnitedHealth. Kaiser's answers to questions that arose at the last meeting are in your packet. I also want to let folks in the audience know that they're available in the back of the room. over there. That concludes my opening remarks. I'm available for any questions.
Thank you. Seeing none. Oh, we have one. Here we go. Ms. Taylor.
Sorry about that, Mr. Chair. Thank you. The Cottage Health issue, I'm just trying to, we have members in the area, so if they don't come, if they're at an impasse and they don't come to an agreement, and we're urging them to come to an agreement.
Correct. We've sent a letter to Cottage. We've been on the phone to Cottage multiple times and with Anthem multiple times, and are pressing them to come to an agreement.
I don't know that we can discuss this or not, but do we know what the sticking points are?
I don't want to go into a lot of detail here because it's a private negotiation. Considerations of cost are always front and center in these issues. We want to make sure, obviously, that everyone is focused on the potential harm to our members in the area as well.
All right. Well, thank you. Maybe we can talk offline about this.
All right, thank you. Seeing no other, pardon? Push your button. Ms. Green-Ross.
How, with respect to our contract with the plan, how would that disruption affect the terms of our contract? Are they bound by our contract with them to provide service that's more accessible for the members in that area?
Yeah, that's one of the ones that probably not get into too much detail just because of the private nature of it. But the short answer is it differs depending on whether we're talking about members in our PPO, where Anthem is a third-party administrator to benefits that we purchase, versus the HMO, where they're an insured entity. So there's a little bit of a difference in the two cases.
Great. It'd be great to just have an update once we know anything more. Thank you.
Thank you. Seeing no other requests. Bringing to item 4, action and consent, the approval of the November 19th meeting minutes. What's the pleasure of the committee?
Please move it.
Moved by Rubalca, seconded by Taylor. Any discussion on the motion? Seeing none, all in favor say aye.
Aye.
Opposed, no. Motion carries. Item 5, information consent items. There's been a request to take 5C off of consent, so we can get an update on that. So with that, we will move on to 5C. Mr. Moulds.
I have Marta Green here from our team.
There you go.
Thank you. Good morning, Mr. Chair, committee members. Marta Green, CalPERS team member. I'm happy to address any questions you may have about this
Thank
report.
you. Mr. Rubalcava.
Yes, first, thank you. I think this is a very innovative program where we try to provide incentive for members to select a personal doctor and participate in preventive care. I think it was a very concise report, and I thank you for that. But I was a little concerned that under the Future Moms programs, only about 11% have actually enrolled, and I was wondering what outreach efforts. I know Anthem's trying to reach out to the health benefit officers, but what can be done to, I mean, this is a beautiful program, and I wish more expectant mothers would take advantage. So I was wondering what efforts we can do to help, or what resources are available to promote this program, which is very beneficial.
Great question. Thank you for it. So in addition to reaching out to the health benefit officers, Anthem's clinical team is also reaching out to the providers that are known to be providing services to expectant women, to try to get to them earlier in their pregnancy to encourage them to participate in the program. One of the challenges Anthem faces is that there may be a lag in time before Anthem, through the claims data that they receive, know that a woman is expecting, because they need to see claims specific to the fact that she's expecting. And so by getting the providers that are providing these services to the women in advance of them presenting as pregnant, they can encourage them earlier in the pregnancy and hopefully increase uptake. So between the health benefit officers, which usually know earlier in a pregnancy, and they can encourage the women to uptake in the program, as well as the providers, as soon as a woman presents who is pregnant, that she can then join the program. So those are the two strategies that they're implementing. But we did, like you noticed, that the uptake was much lower than the other health-related incentives in the program.
There's also an app. Does the app also work for this program?
I actually don't know the answer to that question, but I'm happy to research it.
Because I wonder if that could be a way to reach out to them. I know. So,
It's an excellent question, and I will find out and get back to you.
thank you. I think I really appreciate the report and look forward to next quarter's report. Thank you.
Thank you.
Very good. Thank you very much. No other questions. Appreciate it. Okay, it takes us to item 6, information item. Mr. Molds.
I'm going to turn this one over to Dr. Logan.
Very good. Good morning, Dr. Logan.
Sorry.
Other side. The other side. There you go.
Good morning. How does
Morning.
that sound? Okay. Thank you, Mr. Chair, and good morning again. My name is Julia Logan, CalPERS team member. If I may, I would like to take a moment of personal privilege to honor an important person in my life who was taken too soon.
Please do.
A few weeks ago, I was painfully reminded how mental health personally impacts all of us. My 8-year-old son's devoted and wonderful second-grade teacher took her own life a few days before Thanksgiving. She was full of life, passion, and was easily the best teacher my kids will ever have. She taught her students and her community to love and respect each other and our differences. Our community and world lost a unique and amazing soul. Her life and death will have a lifelong effect on my children and thousands of others in our community. Her family hopes that something positive will emerge as a result of her suicide, starting with more widespread understanding that mental illness is nothing to be ashamed of. At her memorial service a few days ago, her husband said that mental health is something that we should all talk about and be open about so that we can make a difference in people's lives and prevent the unthinkable. And that's my hope, too. And so I thank you for listening, and thank you all for continuing to discuss mental health so openly. I really appreciate it.
Thank you for sharing with us.
Thank you. So, on with our program. Over the last several months, this committee has taken a closer look at how mental health is delivered to CalPERS members and how CalPERS is working strategically and innovatively with our health plans and other stakeholders to achieve mental and physical wellness for our members. As a quick recap, in August of this year, CalPERS team members presented an overview of mental health disorders, their social, financial, and physical impacts, and discussed barriers to achieve mental health wellness, including stigma and a shortage of mental health care providers. At last month's PHBC, the Department of Managed Healthcare presented on their responsibility to protect CalPERS members' healthcare rights and ensure a stable healthcare delivery system through their enforcement of the Knox-Keene Act and the Mental Health Parity and Addiction Equity Act of 2008. Additionally, Kaiser Permanente provided a report on their own challenges and innovations regarding mental health access and treatment, using a standard set of guidelines that CalPERS team members put together based on PHBC feedback. The committee requested that all the large health plans present using the same set of guidelines. Today, we will be hearing from the 3 remaining health plans with large CalPERS membership: Anthem Blue Cross, Blue Shield of California, and UnitedHealth. They will each provide an overview of efforts to improve mental health access and services for CalPERS members, and will also demonstrate how they're integrating mental health and primary care, addressing the social drivers of health, and are complying with mental health parity laws. As you will hear throughout their presentations, each of these three health plans has different ways in which they deliver or contract to deliver their behavioral health services, including using an affiliated company or a separately contracted behavioral health plan. From Anthem Blue Cross, we will have Dr. Robert Friedman, Managing Medical Director at Anthem Blue Cross. From Blue Shield, Dr. Michael Millman, Behavioral Health Clinical Director, Dan Prettyman, Vice President and General Manager, CalPERS and Federal Employees Program. And for the Q&A portion, Dr. Millman and Mr. Prettyman will be joined by Blue Shield's Mental Health Service Administrator, Magellan Health, represented by Dr. Tasha Larios, Chief Operating Officer of California Markets. And finally, from UnitedHealth, Dr. Jeffrey Meyerhoff, Senior National Medical Director, Optum Behavioral Health, and Dr. Dennis Sheh, Senior Medical Director, UnitedHealth, will be presenting. To be able to get through all three of these presentations, we ask that you hold questions until all three presentations are complete. And with that, I will now invite Dr. Robert Friedman from Anthem Blue Cross to present.
Thank you very much. Thanks for that introduction, and sorry for the loss. Thank you, everybody, for inviting us here today. My name is Rob Friedman. I'm a child, adolescent, and adult psychiatrist. I am still in practice and a provider of behavioral health services in San Diego, and also the managing medical director for Anthem Blue Cross Behavioral Health, and focus mostly on the West region and California. Anthem has made tremendous strides in the past several years in enhancing behavioral health services and bolstering up what Anthem can do and a health plan can do to help address some of the challenging issues that we face in the state and, frankly, the nation regarding access, coordination of care services, and happy to go through some of a quick summary of what Anthem does. Is somebody advancing the slides, or am I doing that, or there are no slides? All right, thanks. So I think CalPERS had posed some questions to us about the top diagnoses and by diagnosis and cost, and it shouldn't be a surprise that it's pretty much we are faced with a high percentage of depressive diagnoses. When we look at really what kind of diagnoses are most prevalent, it's some variation of depression and anxiety. I think we know that 1 out of 4 people suffer mental illness at some point in our country, and 1 out of 5 people suffer depression. I think we've all become much more aware over the past few years that identifying issues like depression, substance abuse, and improving access for members who suffer from those disorders to get treatment not only improves their depression and substance use disorders, but also improves their physical health outcomes and compliance with treatment. So Anthem has taken a whole person approach to healthcare, and recognizing that, of course, you can't separate the physical from the mental, and Anthem, being one integrated health plan, has all of the management of physical health and mental health services under one umbrella. There's one record system, there's coordination of care between the physical health medical directors and clinicians, as well as the behavioral health medical directors and clinicians, because it's an integrated health plan. On the mental health side, we approach care for our members and your members by having 2 parallel systems, a utilization management system and a case management system. And these are all licensed professionals who work hand in hand to make sure on the utilization side that people are getting the appropriate treatment, the medically necessary treatment, and trying to steer people towards evidence-based treatments. And on the case management side, also licensed professionals that are more member-facing, clinician-facing, and help members access treatment and coordinate care between their medical providers, their behavioral health providers, discharges from hospitals, and getting the resources that they need in the community. So again, of course, you've heard the expressions, the right care at the right place, better coordination of care. The case managers follow patients from the time they may be admitted to the hospital through discharge, and the importance of finding follow-up care in the community. Because everything is under one umbrella, we're able to coordinate medical and behavioral care, as I said. So we have medical case managers who are routinely reviewing medical cases, complex care cases, and behavioral health case managers are participating in those treatment team discussions. So there's a flow of information back and forth between the medical side, the behavioral side, at the utilization level, and at the case management level. We all know that access is one of the biggest problems facing our communities. several years ago, Anthem introduced a live health online for Anthem members. They can access a telehealth service directly from their phone, their tablet, their computer by just clicking a button on the screen, and it'll pull up therapists and psychiatrists that have availability. Where it used to take sometimes 4 weeks to get in to see a therapist, now somebody can find a therapist who's available within 4 days, typically. Psychiatrists, it takes months to get in, and now with Live Health Online, the average time to get in has been reduced to less than 10 days. The satisfaction measures are taken on Live Health Online, and these are Anthem providers already. They're in-network providers that are having this as an add-on service, and the satisfaction is extremely high for patients, members that are using that service. So the collaboration and coordination of care between behavioral health and medical providers is also a focus, and finding ways to help primary care doctors and behavioral health providers work together has also been a focus. There's a whole team that's been put into place to incentivize the coordination of care and the collaborative care model through value-based reimbursement, and supporting the medical behavioral integration through those efforts. Through outcome measures, if behavioral health providers are coordinating care with primary care clinicians, they have the opportunity to get an increase in their pay for the upcoming year. And that program was just launched like 2 years ago, and it's increasing and being used throughout California. Same with substance abuse facilities. We know that one way to try to decrease the relapse rate is to make sure people get appointments upon discharge rather than just having a revolving door and turned back out onto the street. So the substance abuse facilities are also incented to make sure their patients get appointments immediately post-discharge, and if they do, then they have the opportunity to get a higher reimbursement rate going forward. One of the questions was, what does Anthem do, or what do health plans do to ensure the quality of care? And there's an elaborate quality improvement program. There's one that focuses on behavioral health. We look at the needs and for where improvements can be made. A big focus of the behavioral health quality improvement program this past few years is focused on the opioid epidemic, trying to increase the providers that are able to prescribe medication-assisted treatment, to make sure that those getting medication-assisted treatment are also getting quality medication-assisted treatment, which means behavioral health therapeutic interventions, not just the medication. And we monitor and measure the various programs that impact behavioral health and members with behavioral health conditions. There was a question about the social determinants of healthcare. Well, there are two ways that Anthem has gone about this, and this is, a relatively new concept that's getting a lot more attention at the health plan level. The case managers that I mentioned work with members to help make sure they have transportation, that they have access to care, and that's a big role for case management. We know that people need safe housing, they need transportation to get to appointments, and they need healthy food. Through the Anthem Foundation, there are programs for grants to make sure that communities with those kind of needs receive funding and grants for food banks, cooking classes, and support at the local level. I think we'll see more of that on the commercial side. I think, Anthem being a provider of the government business, Medicaid, Medi-Cal, and also on the commercial side, I think there's an opportunity to leverage a lot of the programs that have fiscally been able to be implemented on the government business kind of side and leverage that for the commercial side, and we're seeing more of that. Okay, I think that is the end of my slides, and I hope I didn't take too much time, and thanks for your attention.
Thank you very much. You did not take too much time. Great information.
Thank you. I will now turn it over to Mr. Friedman on behalf of Blue Shield.
Thank you, Dr. Logan. All right, thank you, Dr. Logan. Blue Shield is sorry to hear of your family's loss. Hello, good morning, Mr. Chair and committee members. My name is Dan Prettyman, and I'm the Vice President of the CalPERS and Federal Employee Programs at Blue Shield of California. Thank you for inviting us to participate in today's discussion, and we appreciate CalPERS' attention and commitment to ensuring appropriate mental health care for our members. At Blue Shield, we recognize the importance of mental health and partner with Magellan Health to provide services to our members, our employees, and the communities we serve. Joining me today is Dr. Michael Millman from Blue Shield.
Good morning. My name is Dr. Michael Millman. I'm a clinical psychologist, clinical director for behavioral health at Blue Shield of California.
Also joining us today to answer any questions you may have is our Dr. Tasha Larios from Magellan Health.
Hi, good morning. My name is Tasha Larios. I'm dual board certified in primary care and rear foot surgery. I spent 13 years in the military, so I continue my active reserve as a primary care provider. I'm really happy to be here. Mental health means a lot to me with the service members that I've seen go through various issues, and integration is really key to helping to serve our members. So thank you for having me.
Per your request today, we will speak to a number of ways that Blue Shield ensures CalPERS members receive the proper mental health care they deserve. And our focus will be based on the questions the CalPERS team previously provided. Here, of course, are those questions that we have been asked to discuss, which are addressed throughout today's presentation, and the corresponding slides to those questions are identified here. I will now hand it off to Dr. Michael Millman to provide further insights on our approach.
Thank you. To highlight our top 5 mental health diagnoses by prevalence and cost for our CalPERS population, you will see that both lists have diagnoses surrounding autism, anxiety, and depression, with a slight difference between the rankings within the two lists. Keep in mind this information will look different depending on how you pull the data. For instance, if we put all the depressive disorders into a single category rather than listing them separately, you would likely see depression move to the top of the list. Throughout our discussion, we will highlight some of the programs, services, and initiatives Blue Shield is undertaking. Next slide. During the last board meeting, Dr. Logan referenced a number of alarming statistics associated with mental health in the CalPERS population. Recognizing these challenges, Blue Shield is committed to helping improve access and quality of care. Blue Shield partners with Magellan Health to access a broad provider network of almost 12,000 behavioral health clinicians, which has grown by 23% over the last 5 years. Magellan Health has a dedicated team that recruits both facility and individual providers as we work to establish and maintain strong relationships. Blue Shield monitors and partners with Magellan Health in this statewide effort. In addition to traditional network growth, we see a huge opportunity to leverage telebehavioral health. We continue to expand the telebehavioral health network, providing easy and secure access for our members through a mobile device at a time and place that is convenient for them. Next slide. You also asked us to speak to screening and treatment for mental health and chronic health comorbidity. In addition to the importance of continuing to improve access to providers, we also see an opportunity to further improve the integration between behavioral health and medical care. Behavioral health conditions add significantly to the overall cost of care are frequently treated inadequately. To help improve integration, we screen for mental health and chronic medical conditions in a variety of ways. We leverage information from medical and pharmacy claims to proactively identify members with unmet mental health needs. We have a chronic condition program that identifies mental health condition and refers members to appropriate resources. We also leverage patient health questionnaires to screen for members' needs, connect them to treatment, and enroll them in Blue Shield's Shield Support Program. Shield Support includes access to a team of co-located mental health and medical professionals, offering personalized care and support, including care coordination, case management, and home visits. Through these integrated behavioral health and medical care programs, we are better able to support our members. We are able to improve health outcomes and lower costs.
Mental health stigma has long been prevalent throughout our society. Recently, Blue Shield has taken action to address the mental health stigma in two important segments of our populations: our students and our first responders. The following two slides will speak to Blue Shield's approach to improve mental health awareness and mitigate the stigma in both these populations. With 1 in 5 students having a serious mental health need and too few of those not understanding how to seek help, breaking down the stigma of asking for help is crucial. Earlier this month, Blue Shield announced an initiative that will do just that, called the Blue Sky Initiative. Blue Sky is a statewide multi-year effort to support mental health care for California students. It will enhance awareness, increase advocacy, and improve access to mental health services for students across the state. The program provides additional mental health clinicians in the schools, trains teachers to recognize the typical signs and symptoms of mental health illness, and empowers students to overcome mental health stigma and get the help they need. Blue Shield is proud to partner with the California Department of Education and other nonprofit organizations to support mental health for California students through this Blue Sky Initiative. Dr. Millman will now discuss Blue Shield's work with our first responders.
We have a tremendous amount of respect and appreciation for our first responders. They make a tremendous sacrifice on a daily basis to help keep us and our families safe and healthy, which unfortunately often impacts the health of the first responder themselves. We recognize first responders also face a challenge with the stigma surrounding the use of mental health services. Some of the examples of our commitments to help include our focused efforts on employer-based programs that reduce stigma and promote mental wellness. We also are partnering with organizations such as the Center for Firefighter Behavioral Health to give them access to technology-based resources. And to reduce the negative impacts of stress and trauma amongst first responders, we're working to offer mental health first aid training program for first responders. Next slide. Moving on to embedding mental health in primary care, we recognize the need for all care to be coordinated and with the primary care physicians at the center of the care hub. We believe that behavioral health must be embedded to ensure whole person care. To help, we have implemented a number of strategies. One example is that we have provided our primary care physicians with a behavioral health toolkit that supports the interactions with CalPERS members. This toolkit gives providers access to guidelines, referral information, and screening tools. Blue Shield has also partnered with our medical groups and primary care physicians to provide space for members to access telebehavioral health services in primary care practices. Next slide, please. To address your questions on mental health parity compliance, Blue Shield and Magellan partner to provide ongoing monitoring and compliance with all parity laws. Planned benefit changes and business operations are evaluated prior to the implementation for parity compliance. Both Blue Shield and Magellan Health are audited by the Department of Managed Health Care for continued compliance with mental health parity regulations. Next slide. Research shows that the majority of a person's health is related to social drivers of health, such as socioeconomic factors, health behaviors, and a person's physical environment. In looking at the impact of social drivers on health, an example of what Blue Shield is doing to address these drivers takes place right here in Sacramento. In Sacramento, we've identified health outcomes are generally impacted by transportation barriers. we have partnered with Lyft, the rideshare company, to offer our members no-cost medical transportation to and from appointments with one of our Sacramento-based providers. This program can potentially benefit over 500 Blue Shield CalPERS members. Additionally, we have a suite of clinically tested wellness programs for our members that address several key health behaviors such as smoking cessation, diabetes prevention, and fitness club discounts. Dan will now share a few comments to conclude our presentation.
I'd like to close our presentation today by thanking the board for giving Blue Shield this opportunity to speak on this critical topic that impacts each of us in one form or another. Thank you again.
Okay, I will now turn it over to Drs. Meyerhoff and Sheh from UnitedHealth.
Thank you so much. Okay, can you hear me okay? Thank you. And if you could pass down the slide changer, I can then not have somebody else do that. So I'd like to thank the chairman and the committee for having us today. It's really an opportunity to be able to talk about some of the solutions that UnitedHealthcare has for our members with mental health and substance use disorders. And Dr. Logan, thank you as well, and I really am sorry to hear about what's happened, and it really speaks to the need for access to mental health services. But even beyond access, it really goes to engagement as well, because we can get people to a provider, but they don't always stay, or it's not the right fit, or it's not how they want to get their care. So we really have worked over the last few years to expand the way in which our members get care, not only access, but also in the way that they want to have it, including supporting PCPs if that is where they choose to get their mental health care. So if we go to the agenda page, which is the next slide, I just want to tell you we're going to cover all the questions that you gave us about access, which is our biggest focus. Integrated care. I am a senior national medical director at Optum Behavioral, which is owned by UnitedHealth. And my primary job is medical behavioral integrative solutions. And then we'll talk about the social determinants of health, Parity, and some of your stats with your membership. If you go to the next page, you can't have access without addressing the shame and stigma that comes along with having a mental health or substance use disorder diagnosis. That is a huge barrier to people seeking treatment and getting the care that they need. And we recognize that, and as part of our solution to getting access, as we really are aggressively trying to change this conversation, we've been working with national organizations that are well respected in this area. This year, we partnered with Coping After Suicide, Give an Hour, which is an organization that asks therapists to donate 1 hour a week to military and veterans. PsychHub, which is a tremendous online source for psychiatric information. Shatterproof, which focuses on substance use conditions, and Stamp Out Stigma campaign. And this next year, we're going to expand that because we know that's not enough to the American Foundation of Suicide Prevention, Mental Health America. We're going to expand our mental health first aid offerings through the National Council for Behavioral Health. We're going to work with a group called Mental Health Innovations that tries to kind of approach this stigma issue in alternative ways. The Trevor Project, which focuses on the LGBTQ+ community, which has a huge prevalence of some of these issues. And we're also partnering with University of Maryland to do some more research on what else do we need to do to change this conversation.
Dr. Meyerhoff, I hate to interrupt, but would you mind advancing the slide?
Oh, I'm so sorry. I said I would do it, and then I never did. I'm really excited. Sorry. Okay, so the next one is really what are we doing at the workplace level? Ooh, I hope this didn't go on. Yeah. So we also have campaigns at the workplace level to try to reduce stigma. And we're doing that for CalPERS currently, working with leadership to kind of talk about how do we communicate the importance of behavioral health wellness, how do we create a culture within the workplace environment that is more supportive of people who have these conditions, how do we connect them with similarity to physical conditions, and how do we kind of engage your members in more kind of preventative wellness programs. We also have efforts that are at the member level to try to reduce stigma. We have care advocates that help people understand the importance of seeking care. We make sure people know and understand and use their benefits when necessary. We work to provide early intervention, screening, which we'll talk about in a minute, because the quicker we get in front of this, the less severe, hopefully, the condition's going to become. And again, even focusing with members regarding this is really equivalent to having a medical condition. So we're going to talk a little bit about our PCP connection, and then we'll continue. I'll continue.
I'm Dennis Shem, a senior medical director at UnitedHealth. Background is in internal medicine and geriatric medicine, and I wanted to talk a little bit about our collaboration with our PCPs on behavioral health. So we share with them various clinical resources, including information about cultural competency, screening for depression, alcohol, and substance misuse, management of ADHD, and patient education materials. We also provide real-time data on clinical care opportunities for our PCPs. As an example, for our Medicare members, we share with our PCP reports that include ER visits, inpatient hospitalization, admissions, and discharges, which includes behavioral health hospitalizations in those reports. And we don't differentiate between medical and behavioral health hospitalizations, and we ask our PCPs to outreach to every member, every one of their patients after a hospital discharge to follow up on their patient. The majority of our members in our disease and care management programs are screened for depression, and if the member has an elevated score, with the member's permission, we share the results of that assessment with the PCP. And then we also have an Optum, UnitedHealthcare Optum Behavioral Health clinical advocate reach out to the member to assist them in getting additional care. And finally, an example of how we're working on addressing and supporting our members and PCPs around the social determinants of health. Our Medicare members have as available to them a free annual in-home assessment, and the results of that assessment is sent to the PCP, and the members also given a checklist of things to follow up and discuss with their PCP. And in that assessment, it includes evaluation of things such as safety in the home, access to food, utilities, transportation, medical care, income level, work situation, VA status, and evidence of social isolation. And between January and September 2019, 1,075 CalPERS Medicare members were identified and were referred to a UnitedHealthcare social worker for additional support around a social issue that we identified.
And that in-home assessment also includes mental health screening and referrals to behavioral if necessary. And United Behavioral Health, Optum Behavioral, has the largest network of providers in the country. We have an extensive network, but we know just having a large network doesn't necessarily mean that you have access. And so we have actually focused on developing what we call our Express Access Network, where we actually contract with providers to get a member into care within 5 days. The industry standard, as you heard, is closer to 2 weeks. So this is a face-to-face appointment within 5 days for our members when they need more immediate access. We also have the largest network of virtual providers in the country for telemental health, and we actually own, thank you, we actually own the largest provider of telemental services, Genoa Healthcare. So they are actually one of our affiliates, and they're the largest provider of telemental health, including about 3,000 psychiatrists and nurse practitioners. We also have a huge network of specialty networks, ABA, medication-assisted treatment, and autism spectrum providers. Next slide. So for California, because obviously that's where you're interested, over the last couple of years, we have increased your behavioral health network by 22%. We've increased the number of substance use disorder facilities by almost 50%. We've increased the number of medication-assisted treatment providers to prevent worsening of the opioid epidemic by 30%. We've increased the express access appointments that I talked about by almost 50%. Our virtual visits went up 174% in California, and our ABA practices, we increased that by 33%. So really working aggressively to make sure your members have good access to care throughout the state. The other thing that we do to improve access is actually partner with providers at higher levels of care. All that we've talked about so far is our outpatient services, but at higher levels of care, it's really important that we have access as well. So one of the things we've done is, instead of the industry standard, which is to review a case every couple days to make sure it meets medical necessity, we actually use our data, and we have a lot of data, and compare it to severity, age, diagnosis, and we actually know what the average length of stay is going to be for that member at that level of care. And we go ahead and we authorize that average length of stay plus 1 extra day to be able to get out of the provider's way and let them really take good care of your members. The reason we get involved after that is if someone stays longer, we know something is different about that case. It's not your average bipolar case, let's say. And so they might need more services when they get out of the hospital. They might need something else. They might need some increased care engagement. And so we partner with providers, and this really had a really positive effect on the care that our members receive, because not only do we get out of their way, but we also help them provide solutions when a case really isn't your standard case. We also have really revamped our care engagement program. It used to be our case management program, and it really is about engaging members. And we've gone beyond just looking at behavioral claims and behavioral clinical data. We actually bring in medical claims, medical data, pharmacy data, and that gives us a much more holistic view of your members. And therefore, we can really figure out who's falling through the cracks, who needs more high touch, and who could we kind of put those high-level resources towards, whereas who could benefit from more educational resources and lower-level touch services. So it's really been a great thing. And we, of course, in addition to all that, transition everybody out of the hospital and make sure they get a timely appointment once they're leaving a substance use facility or an inpatient facility. We also, and I'm almost done, but we also did a study, because one of the problems with medical behavioral integration is there was a study about 10 years ago that said if you just chase everybody with a comorbid disorder, you're going to save tons of money. And nobody in the industry has really managed to achieve those savings. So we looked at the study, found some serious problems with it, and redid our own study looking at 60,000 match conditions. And what we found is it's not everybody. That in fact, in this slide, it's really a heterogeneous population, meaning that 14% of the population has a comorbid medical and behavioral condition, but only 25% of that 14% is driving 80% of healthcare costs in that group. So historically, we've been chasing the other 75% with really expensive resources, and that has not paid off. We've been able to figure out and actually create an algorithm that helps us identify who are these 25%, really throw those high-level resources at them, case managers, medical doctors, behavioral, psychiatrists within the organization, partnering with their providers in the community. And we've been able to have a tremendous outcome with wellness, improved wellness in this chronically medically ill population, as well as serious reduction in total cost of care for this group. Some of our initiatives in the next slide for medical behavioral integrative activities are screening, as we talked about. We now have every disease management program that sees your members screening for depression, anxiety, substance use. We have programs that if somebody has a chronic medical condition and depression and anxiety, they can get an 8-week session of a coaching once a week and cognitive behavioral therapy once a week. And after 8 weeks, their total cost of care dramatically declines, as well, and their wellness, their adherence to treatment goes way up. And we also, of course, offer all the other services I talked about, and we report on this. So we report to you how we're doing with our medical behavioral integrative activities, and the reporting helps us continually improve the program. We address social determinants of health. We actually have an algorithm that identifies people who might be falling through the cracks because of their barriers to care. Our care advocates always inquire whenever they're talking to members, what are the barriers that they're receiving. We have a connector tool that helps reach the community resources necessary to help improve transportation, housing, how to get to the pharmacy, whatever it is that they need. Our care advocates really work to close those gaps in care, because we know without closing those gaps in care, these people are going to fall through the crack and not get the proper mental health and substance use care that they need. We comply with Parity. We partner extensively with the health plan in this regard, and we have an annual assessment of our tool, and we also comply with your California-specific guidelines, which are different, and the Department of Managed Healthcare surveys. And then finally, you did ask about your diagnoses. Your prevalence is really comparable to our National Book of Business, which I think is really interesting. There are very little differences between the way your membership prevalence comes out and our National Book of Business, and the same with cost. There's a little more in your basic plan, a little more anxiety than maybe in the National Book of Business, but really it is quite equivalent, and you can certainly look through that list and see where the costs and the preponderance of prevalence is. I'm really appreciative that you let me talk today and come in front of you. Thank you.
I'd like to thank all of our presenters, and now we're all open for any questions you may have.
Excellent, thank you, and thank all of you for being here and for offering such good comments. It's very enlightening to me to see the use of virtual medicine, telemedicine, et cetera, especially in this arena, because we know a lot of folks, one of their biggest hurdles is actually leaving their home. So I think that's good that we're reaching out and trying to find other ways to access these folks. I do have a question, however, for all of you. It seems it's an industry-wide issue that it's harder and harder to find professionals in this field. Is that your knowledge as well? I mean, we keep seeing, well, there's longer and longer wait times, and some of that is because there just aren't enough professionals out there. Do you find that in your book of business? Any of you?
Yes, I mean, that's absolutely a huge barrier to getting access, and I think it's one of the reasons that we all have talked about alternative solutions, because we can only create so many providers. And we have tried to support initiatives even at the kind of medical school level to try to encourage more graduates to go into mental health and psychiatry. But, you know, that's the long game, and it takes a long time. So we had to really come up with solutions for the short term. And yes, I mean, that's the reality all over the country, especially in rural areas. We know how difficult it is to find a provider, and that's why I think we're all talking here today about really going to telemental health, because that does level the playing field, at least, especially for people in a rural area.
Thank you.
Yeah, I would concur. I think, you know, I'm a child psychiatrist. There's, I think, only 4,000 or so child psychiatrists in the country. Many psychiatrists and child psychiatrists are, I think half are like above the age of 50 and, you know, approaching retirement. So it's really more of a national effort to try to encourage more medical students to go into psychiatry. I think we're all of us are understanding the importance of other licensures like nurse practitioners and getting them trained in mental health. There are programs increasing to train mental health nurse practitioners, and I think we all need to understand that we need to embrace that. And then finally, really the whole collaborative care model, as has been talked about by, I think, all of us, you know, we need to support primary care physicians in recognizing, diagnosing, and treating mental health and substance abuse conditions by specialists being available either on site or for referrals or through telehealth mechanisms to help bolster their treatment. But it's a shortage. I will say, on a personal level, I'm doing what I can. My daughter is graduating as a resident in psychiatry this year, so I told her she had to do it. So
add one more. Very good.
So I would like to echo everything that they've said. I would like to include that telehealth we have seen great success within the cardiology and dermatology pairing with primary care. So a few years back, close to 10 years ago, there were issues with finding access to dermatology and cardiology. And that was solved through telehealth initiatives within the PCP clinics. And so Dr. Millman had mentioned that we are pairing our telehealth services with our larger primary care groups at Blue Shield. And that is to introduce the telehealth for mental health diagnoses to members so that there is that comfort level of getting on a video, and perhaps they want 1 or 2 sessions within their primary care office, and after that they want to take them from home and they have that convenience.
Excellent. Thank you all for your comments. Microphone.
Developed telehealth originally because we thought younger people were going to want to get their care that way, and in fact our biggest uptake is in the older population.
Sure. Thank you. All right, we have a number of requests from board members. Mr. Ruffino.
Thank you, Mr. Chair. First of all, I'd like to begin by thanking on behalf of my principal, the great treasurer, State Treasurer Fiona Maub, to each and every one of you here in the panel and to your respective organizations for all that you do for our members and for the public at large. I think we all agree that it's a very, very important and critical work. And also thank you for this update that you give us today. It's very helpful to understand. I do have a few questions for all of you, but I'd like to reflect for a moment and before I begin the question. If you happen to see yesterday's article in the Los Angeles Times, I'm not sure if you happened to see it or not, but it was describing the experiences of our enrollees in that particular story that we're referring to, Kaiser's, attempting to access care from Beacon and Magellan therapists. And if you did not see it, I strongly recommend that you look at it because these folks reported making dozens of calls to therapists who were unable to give them appointments. One person in particular attempted suicide after spending weeks phoning through 60 therapists and awaiting their return calls in an attempt to find a therapist able to care for him. So I guess the general question is, what is Anthem, Blue Shield, UnitedHealth, and so on and so forth? What are you doing to make certain that these provider networks actually deliver appointments and care to patients with mental health conditions? I'd like to begin with that question.
So, hi, thank you for that question. It is very important to ensure that members have access to care in a timely manner, and it is something that we've been discussing as far as provider availability throughout the state. Again, we've discussed how we are increasing our access by recruiting network providers, by offering additional options in how members seek care through telehealth. And we still are seeing articles that you were pointing out. And so what we have done on Blue Shield's side is we do offer what we call appointment assistance. So we are able to call and identify providers within the 10, 14-day, and 6-hour timeframes that regulatory-wise we adhere to. And that is something that we have done to offer assistance to our members.
Yeah, again, it's just a real problem. You know, it's a supply and demand issue, and it's what happens is, let's say a new provider joins any of our networks, they're going to be booked within 3 months, their practices are now full, and it's a challenge to get them to see more patients. Of course, there's some geographic variability, but because there's such a shortage of providers and people wanting to access care, which is a good thing, it is an ongoing problem. But I think we're all trying to come up with the same solutions: increase the network, bring more providers into the network, make it desirable for them to want to do that by making the rates attractable, so they will do that. Telehealth is a way to increase access. Anthem is actually starting a pilot project next month in January for California for, it's going to be hard for me to say this, but I'm going to say it, chat therapy. Again, we want to reach people where they're at, and there's a huge population that uses texting. And if we can engage people through texting services, then we can pull them into telehealth and even bridge a gap to get them into an online appointment, an online or an in-person appointment. Anthem is trying to increase the network of providers through the pending merger with Beacon that you've probably heard about, and that's going to increase our network of providers as well. So I think all of us know that access is a problem, and there are a number of things that we're all trying to do to address it.
So at UnitedHealthcare, we make ourselves available to our members 24 hours a day, 7 days a week. We have a care advocate on the phone to help assess people and assess what their need is at that time. And then if indeed they need an appointment in the community, we ask them how they want to receive that. So it could be telehealth, it could be an in-person appointment, it could be they want to call a few people and kind of interview them. So if they want to call and interview a few people, we do that, we give them a few names. But if they call back, then we actually pass that on to a team that does nothing but find people appointments, so that we take the member out of those 60 calls, and we really do that for them and make sure they have an appointment in hand. Also, our telehealth system, a lot of these shops are 1-2 mom and pop kind of shops. And so for telehealth, we actually will provide any of our network providers who don't have access to a HIPAA compliant system, our own system. And what that includes is it's HIPAA compliant. People can get their care right in their home from their computer, but also it has online scheduling for that provider. So the member can go into their computer, look at the provider's appointment schedule, and schedule that appointment right there and know that they have an appointment.
With respect to shortage, and first of all, by the way, thank you for your comments, and thank you for everything that we are trying to do. Whether it's Anthem with the Live Health Online, I think it's awesome, and some of the other programs. But we are keeping hearing about shortages, and of course it's real. There's no questions about it. Everybody acknowledges. But I wanted to ask generally, could it be true that is the low reimbursement rate paid to therapists and psychiatrists who participate in the Beacon and Magellan network, could that potentially be also an issue? As I understand it, for example, I've seen reports that reimbursement rates have not been increased for 8 years or more. And that in some counties, the rates paid by these networks are lower than the Medi-Cal program's reimbursement rate. So do you know what your rates are and how these rates compare to Medi-Cal rates? How have the rates changed over the past 10 years? Can you provide some general, I know possibly you may not disclose them, or maybe you can to our staff, but are you aware of that issue? Because I believe that issue is also contributing, to this difficulty. Maybe. I'm not sure. What's your thoughts?
Hi, thank you again. So, absolutely. I think anytime you discuss insurance, reimbursements, and access to care, the rates have to be discussed. And so we do actively look at our network of where we have our providers. We look at the benchmarks of TRICARE and Medicare for reimbursements, and we actively pursue providers within those areas where we are currently needing additional expertise, and we are negotiating 2 terms. So there may have been issues in the past. I guess you had mentioned 10 years. I apologize, I haven't been at Magellan for 10 years, but looking over it, I could see that there was probably some issues with reimbursements in the past, but that is something that we actively look at.
Okay, thank you. One last question for, sorry.
No, I'm happy to pipe in. I mean, I think, it's as a physician that's not my responsibility to negotiate rates, but I do work with the provider network teams that negotiate with providers in the community, and I think it's a fair state. I can't speak for Beacon or Magellan, I can speak for Anthem, and I think they're constantly evaluating the rates in the communities, and they will negotiate rates that are competitive to bring people into the networks where there's a supply and demand need. There are some areas where people's rates are higher than other areas because of that need. But I think you're right. The cost of living goes up, and the rates to reimburse providers needs to parallel that at least, so that we can get more people into the network. It's a little more complicated. I'll just make another point, because another experience is if you're a provider in the community and you have a very busy practice, you then will have your cash rates. And as soon as health plans raise their rates for reimbursement, providers then raise their cash rates, and then you're constantly chasing a higher rate in the community. So a provider will say, well, I have, if somebody calls up, they says, well, I have no room to take you, but I do have room if you pay cash, which that shouldn't be happening, but there's an element of that on the provider side also.
And I'll just add in that, yes, UnitedHealthcare also has been guilty of the same problem, where we were contributing to the access problem by not increasing our rates for such a long time. And we recognized that we're not going to solve the access problem unless we change that. So this year, we actually did a substantial rate increase for our provider network. And we have another one scheduled for this next year, because indeed, we need to compete with cash practices, and we need to reimburse providers what they need to be able to take your members.
And that we need to encourage providers to want to join our networks, because we pay them enough and we make it easy for them to treat our patients, our members.
Very good. Thank you. One quick question for Anthem. I know that we saw the announcement that in June you reached a deal to acquire Beacon Health, which obviously is one of the state largest network of mental health providers. I understand that the deal is supposed to close during the fourth quarter of this year. Can you give us an update on the status and whether or not, how will it impact, hopefully positive, I'm sure it will be positive, to provide, again, timely and appropriate outpatient mental health care to our CalPERS members? Sure. I'm not privy to a lot of the private information because all that is very tightly controlled, but the latest I heard was it may be pushed to the first quarter. Every state that's involved has to sign off, and there's a few states that still haven't signed off. So I think to get everything in order, it looks like it's been pushed to the first quarter of 2020. But it still looks like it's on track to happen from what I'm hearing. And I think you're right. Listen, if Anthem and Beacon do it correctly, it's taking the best practices of both of those organizations. It'll expand the network for Anthem/Beacon, because now there are overlapping provider networks on those two organizations, but there are some that aren't overlapping. So it will automatically increase the network. Beacon has a lot of strengths. A lot of their focus has been on the government side, Medi-Cal, Medicaid.
and they've developed some robust case management programs and complex care programs, and I think by picking best practices from both organizations, you're right, it does afford the opportunity to really enhance the delivery of care for members.
We wish you well.
Thanks. Thank you.
Thank you all again for being here and to give us this presentation. Thank you, Mr. Chair.
Thank you. Mr. Rubalca.
Thank you. Very good presentations. Thank you very much, and I thank you for taking this issue very serious, because it is serious to our members. I have a question for each of the plans. Dr. Friedman, in the discussion and on the slide about coordinated care, it seems to be like a coordination between inpatient and outpatient. So what is the utilization, say, inpatient versus outpatient in your system?
What do you mean by what is the utilization?
I mean, what percentage of medical service, health service, mental health services provided outpatient versus inpatient? And the reason I'm asking is on your slide 6, it starts with the title's coordination, but it starts basically with an inpatient setting, it seems to me.
Okay. Well, no. Well, I think there's actually more people receiving care on an outpatient basis, and Anthem doesn't do any utilization management of our outpatient services. We want people to access outpatient services very freely, with the exception of autism services. We do require authorizations, and with a technique called TMS, transcranial magnetic stimulation, we do require a prior authorization to make sure that that's appropriate, so people don't get that if it's not safe or effective for them. But otherwise, if somebody wants to go to a therapist, a psychiatrist, they don't need an authorization. They don't have any kind of limits on how often or how frequent they can see those providers. So we want to make sure people have open access to outpatient care. So actually, I think there's more treatment going on the outpatient basis. When people do access higher levels of care, like inpatient residential treatment, those are the triggers that trigger case management, I think, for all the health plans to try to make sure those folks, when they get out of the hospital, they can access an appointment on an outpatient basis more quickly. I'm not sure if that answered your question directly, but...
No, that's fine. It's because when I first saw the questions formulated, I thought we were going to be, well, from my point of view. And when the question about coordination was how to, the screening, identification, how do you take them, how you identify them, screen them, and take them to the appropriate level of care, I guess. And I was interested,
right?
Because right away it seemed to focus on how once they're in inpatient, how does the coordination follow after that?
Right. Well,
so I thought it was interesting.
Sure. Well, people usually access care, higher levels of care by showing up at an emergency room or directly at a mental health or substance abuse facility, and then a request for coverage of those services comes into the health plan, and then, assuming it meets criteria, there's an authorization provided, and as was said, a number of days are approved, and then there's follow-up reviews to see if patients continue to meet that level of care, and as they improve, they're expected to step down to lower levels of care. Could be going from inpatient to residential, could be going to partial hospital, could be going to an intensive outpatient program. And those decisions are really made by the clinicians who are treating the patient, and if they provide the information to support the services that are being requested, then Anthem and the other health plans will support that and approve that. And then there's the case managers who facilitate people coming from higher levels of care going to outpatient. As Dr. Meyerhoff said and others said, there's people who are actually making phone calls, finding providers, and making sure that they can get an appointment. The responsibility really is at the treating provider level, like the facility has a responsibility to find appointments, but often they need help because they're not as familiar with the networks, or they're just not as incented. So we work together with them to try to help find appointments for people, coordinate that care.
Thank you, Doctor. I had a question for Blue Shield. Dr. Milliman, there was As you can tell, my interest is in the identification screening of an engagement with the patient. In Blue Shield, there's something called co-location of mental health and medical care managers. So I was hoping, and there's a tool where you create a list, I guess, that goes to the PCP. So how is that list created? What are the triggers, and what are the entry points into that list? And how is that toolkit used by the PCP?
Thank you for the question. The toolkit is something that the primary care provider can use. And some of this may be better answered by Dr. Larios, but I'll give it a go here for the first part of this. The co-located part is Magellan has licensed clinical staff that actually work out of one of our Blue Shield offices and are integrated with what we call medical care solutions, where is the department where I work. And so they interact with our physicians there directly, and our nurses who do medical management. They also interact with the concierge team that provides extra supportive services to members, including CalPERS. Some of the other screenings are done through the Magellan staff, and I'm going to let Dr. Larios talk a little bit about that.
Thank you. So we do have our co-located care managers that are capable of screening members utilizing national screening tools for depression, anxiety, substance use disorders, and from there those screenings are utilized to help gauge where the member needs to get care. So if they need an outpatient provider versus a higher level of care provider. We also have our care managers who are out in the field, and they are linking between outpatient providers through the PCP toolkit. So the PCP toolkit is actually a website that links the primary care providers to clinically based practice guidelines. So the primary care provider can go and look at ADHD and the current medications and the best way of treating it should they send them to a therapist, in addition to giving them medications. They also have a direct link to our clinicians that are field-based and our psychiatrists, our board-certified psychiatrists. So if they have any questions about medications or where they should be taking the treatment of the member, they can outreach in those regards.
Thank you.
Thank you.
I had one final question here, Mr. Chair. For UnitedHealth, Dr. Mayforth. Sorry about that. So again, my interest is the continuation of care and the integration. So I maybe I should have asked the Mellon too, but I'll ask. How does the interaction work between Optum and UnitedHealthcare? At what point is there a handoff, or is it integrated, or how does the reimbursement work? And because for most people, I would think, you correct me if I'm wrong, their first interaction would be with their primary care physician. So how does that go from their primary care physician to, say, an Optum service provider? How would that work?
Well, it's a great question, and I might like Dr. Shea also jump in. But, at the PCP level, first of all, Optum and UnitedHealthcare are really just one company, and we are really seamless in the way we do business. Optum being a little more the service side of the company, so that, the networks and providers, and United being a little more of the insurance side of the company. But generally, all of the services, whether they be medical or behavioral, are really seamless in the integration. But at the PCP level, we have a number of initiatives that we engage to try to bring best practices to PCPs. We really want to help support, and especially when you saw our case care engagement grid, that middle group that doesn't drive all the costs but still needs good treatment. If they're getting their care with the PCP, we identify and stratify the entire population, and we assess what do they need. Are they in that top group where they have medical and behavioral risks and they need more intensive care engagement, or are they more in the middle group where we can support their provider that they have? If they have a provider that's a PCP, we will outreach to that provider, let them know what we have found, and also help them with best tools, so best screening tools and best treatment algorithms. And in fact, what we have found is that our PCPs have been really amenable to those conversations and willing to kind of continue to treat that member up until the point when they don't feel that they, are comfortable. The key to this is when they don't feel comfortable, getting them a really quick and easy referral so that they can hand that person off to a provider. And so we are working, especially now that we own the largest provider of telemental health services with a huge number of psychiatrists, we are working to see if we can actually support that PCP right there in their office through an appointment immediately with one of our telemental health providers. So that's the PCP level. We also have the disease management level, which is anybody with a serious chronic medical condition, heart failure, diabetes, all get enrolled in a UnitedHealthcare Optum disease management program, and we work hand in hand with those nurses that manage those members, and we help the nurses really identify any kind of behavioral health condition that might be occurring. They screen everybody now. That was not always the case. And if there's a serious condition, they will refer it over to us, or like I said, one of our providers, like the Able To program, where they actually address those chronic medically ill members that have depression and anxiety. So we have a number of, we also have a program called Life Solutions for those nurses, where we actually just kind of jump in and coach somebody who might have a behavioral health or substance use condition but is not really interested in seeking treatment. We just provide them a coach to help them kind of meet their needs, their goals, and see at what point they might be amenable to moving into some behavioral health treatment. So that's the kind of integration that we try to provide to your members.
Thank you. Sounds like a very robust program. Thank you. Thank you, Mr. Chair.
Thank you.
I'm very happy to hear that although they have different models and approaches, they are working to interface with our members, and I appreciate that.
Very good. Thank you. Mr. Miller.
Yeah, thank you all for this, the time you're spending with us and your openness to answer our questions and have the discussion. A couple things that kind of come to mind. I happened the other day to be over at the Crocker. I don't know if everybody has been over there, but they've got the Journey to Hope exhibition. And it's art inspired by writing by people about their mental health and its impact on their life. And so it's a wonderful exhibition. And if you go when they have the artists and the writers there, you speak with them. And some of these really common themes came up, both in terms of why they were there and some of the challenges they faced. And the issue of dealing with the stigma and dealing with the judgment and everything to get over those initial barriers to get help. So I'm really encouraged that all of you are really making the effort and the investment, because that's when you get to kind of root cause, why, you get to that. It's certainly on our members' side of recognizing and being aware and accessing help. But the other thing that struck me is in so many of their stories was not just access, but continuity of care. And particularly, as you had mentioned, sir, when there's these comorbidities with especially things like chronic pain, that they run into kind of a one-size-fits-all type approach. And for that 25% or whatever it is, to go through all the hurdles of being required to go through all these approaches that aren't really effective for them, like spending a lot of time with cognitive behavioral therapies that are just frustrating the heck out of them. So again, I'm really encouraged to see that there's some recognitions that we need to get a little more focused on getting the correct care plans, the correct for them. And finally, what it really seems to come down to with a lot of this is capability and capacity issues, whether it be turnover and mobility of professionals, so that patients who finally get to where they've established and are making progress, and suddenly they no longer have access to that person because they moved to another location or another city or changed careers or whatever. And it seems that some of it is at this point at a level that's kind of beyond what the approaches are addressing, and there's almost this artificial shortage of capability and capacity just in terms of having access to the professionals, whether it be physicians or healthcare paraprofessionals, or because the pipeline is constricted right from the get-go in the medical educational systems, and is very constrained in terms of new graduates, in terms of who can be accepted and get through, in terms of the cost, all those barriers. And I'm curious if your organizations or your industry has been looking at how do we change the fundamental model, if necessary, to be able to have the number of nurses, physicians, physicians' assistants, psychiatrists, postgraduate medical programs, where we don't have this really artificially created shortage, because there are plenty of people capable of doing these careers, but the vast majority of them are excluded from the get-go because there's such a limited opportunities for them.
So I can jump in first. First of all, I want to comment on the art show, which is, that's really where we need to find the solutions, is bringing the shame and stigma out into the open and having open conversations about mental health and substance use. And shows like that, I think, really help facilitate that conversation. So I'm glad to hear that that's happening. Number two.
January 5th.
What?
Through January 5th. Right
Okay.
across the street.
Okay, that sounds great. Number two, you're exactly right that, we used to be in the business of telling our members what they needed, when they needed it, and how they needed it. And of course, that wasn't what was important to them, right? That wasn't what they were seeking when they were trying to get help for their substance use disorder or their mental health condition. So we have retrained every one of our frontline care advocates in the art of motivational interviewing. And the focus of that is really to find out from our members what do they want to get out of treatment, and make that the goal of what we focus on. So that they're really, it may just be they want to get to their daughter's graduation in the summer, or a wedding, or they want to be able to walk further, or they want to be able to sleep better. But we need to find out what they want to get out of treatment, not tell them what they should get out of treatment. And so we have completely revamped the way we train our frontline staff to get at that information. And then thirdly, like I said, we're doing our best to support training programs, but I think that changing the reimbursement will make those fields more attractive to go into mental health, and hopefully change some of the kind of trajectory that you're talking about.
If I could add a little bit to what was said here. We have some similar programs, so I won't go over those. And you had mentioned about chronic pain, and that's certainly it was a concern of mine when I was as a provider. And one of the things that we were able to do at Blue Shield recently was to contract with a telebehavioral health provider that focused on two exclusive areas. One is eating disorders, the other is opioids. And in part of that, they, for a local medical group here in the greater Sacramento Bay Area, focus also on issues related to pain management around that. And they came to our attention probably because of the medical group who had had such great success with them. So both Blue Shield and Magellan have separate but very much overlapping networks. and Magellan was able to contract with them this past summer, as well as Blue Shield, to address that. The pipeline portion that you speak of, it's not a major focus as yet, although I'm hoping it will become more of one. But last summer, I personally was able to have talks with one of the local medical schools about how we might work together to develop some sort of relationship to support more behavioral health specialists, both medical and on the therapist side. So, and then I think Dr. Larios, you wanted to add?
Thank you. So I do want to add that we also actively pursue ensuring that our providers that are in network have resources to refer members to. So it can be very frustrating to sit in a silo as a solo practitioner or a small group practitioner where you don't have resources to refer somebody out for food security or for housing or for legal. And so to be able to link members to that through the health plan has been something that Blue Shield and Magellan have been very committed to. We have resources to link members and the providers as well to those resources. And I think expanding further in that realm is really where we've concentrated through 2019 and into 2020, is making sure that there are those links between our network providers so that if there is something that they don't feel comfortable in handling in their outpatient clinic, they either have a higher level of care that they know that they can refer the member to, or they have another provider within our network that they can coordinate with.
I don't have a whole lot to add other than I think your comments about the pipeline maybe, sort of ahead of the curve and maybe where we all need to get to is maybe that challenge provides opportunities for health plans to start looking at ways to support training programs, like nurse practitioners I think there's now a program for primary care nurse practitioners to get a certificate in mental health with a one-year program, and maybe health plans can find ways to support and those types of programs to get more providers into the community.
Yeah. Well, thank you all for your answers and coming out to speak with us today.
Thank you. Mr. Jones.
Yeah, thank you, Mr. Chair. Thank you for the presentation. And our goal is to further improve the treatment to our members. And listening to your presentations and also comments from our board members, committee members, there's some takeaways that there seems to be a lot of work left to be done. And, whether it's dealing with the rates or the reimbursement rates, or whether it's dealing with more resources or staff time dedicated to this area. So what I would like to suggest, Mr. Chair, is that we get an update after giving the providers time to go back and address some of these issues that's been raised today, and then report back to us on progress. Having said that, looking at the UnitedHealth chart of improving access to behavior health care, and I was trying to put some numbers to those percentages because the previous chart there, it talks about national data in terms of numbers, but the percentages talks about California. So what improvements in terms of what are those numbers for California where our members reside?
Sorry. It's a great question. I don't have those numbers on me today. We can get those immediately, okay. But I don't have them on me. So yeah. I'm happy to report back to the committee.
Okay, I appreciate
and
that.
Get you those what those numbers actually are, right. In terms of the entire spectrum of the services that we've increased over the last couple of years.
Okay, appreciate that.
Yep.
Okay.
Thank you. Ms. Middleton.
Okay. Thank you, Mr. Chair. Just coming at the end, most things have already been said, but a couple of them will bear repeating. First, I want to thank Dr. Meyerhoff and Dr. Say in particular for partnering with the Trevor Project. The incidence of the need for access among LGBT youth is greater than it is in the larger population, not because of underlying issues of greater propensity for mental health issues, but because of the discrimination that is faced in the community. So my thanks and congratulations. I am certain that those kinds of approaches need to be followed in all programs. I would like to ask, what more do you believe can be done in working to integrate non-medical doctors into the treatment of the population? Clearly, we are not going to be able to produce the number of MDs that we need within the next few years to provide treatment. Many of the treatments that are needed do not require medical doctors. I'd like to hear more on that area. Any one of you can jump in.
Okay, I'll jump in. Well, thank you for your comments, because it really is important to reiterate that as often as we can, that, there are all kinds of vulnerable populations, and the LGBTQ kids are particularly vulnerable and really need a lot more support. We all up at this table use as many ancillary personnel as we can who are prescribers, so nurse practitioners, physician assistants, but even those specialties now are in hot demand. The unemployment rate for nurse practitioners is 0. We actually, UnitedHealth, with our house calls program, employ the second largest number of nurse practitioners in the country, only second to the VA. And these people either see members in nursing homes almost on a daily basis to try to make sure we get ahead of any kind of, medical or behavioral issues. But they also do these house calls and really visit people at home and really address those social determinants of health, do mental health screenings as well as medical screenings, and really get people connected to the resources that they need. But, and we know PAs, same thing. We need to be able to access that network in a larger way who can prescribe. But I think, there does need to be a conversation about how do we increase prescribing capability, because obviously, we also need to increase probably the therapy capabilities. But it sounded like your question was a little more about psychiatrists and medications, and so we do need to figure that out, and it's one of the reasons that we're looking at this program to help support PCPs do a little more advanced care and give them the out that they need if they get into trouble, because that is where a lot of people do get their primary mental health care today.
I was very pleased to hear comments regarding those that are suffering from opioid abuse and from opioid addiction. My own experience within the workers' compensation system is frequently, very, very frequently, issues of depression and anxiety were underlying and comorbidity with issues of pain. And where we have individuals with opioid addictions, frequently there is a depressive issue as well. Following up, the program to respond directly to first responders is something that is extremely important. I know from conversations in my city with our police officers and our firefighters, they have frequently found themselves in situations where they are exposed to human nature at its worst, and human nature in some of its most vulnerable and difficult situations. And so thank you for that program. And while I'm issuing thanks to Dr. Logan and to all of my colleagues for taking the kind of time and attention that has been taken over the last couple of meetings to issues of mental health, I think speaks very highly of CalPERS and its commitment to the greater health of our community. Thank you.
Thank you. Ms. Oliveros.
Thank you for your presentations. As we were talking about reimbursement rates, I would like to follow up on Mr. Ruffino's questions. I think there was some language around the improvements in the reimbursement rates. I'd like to know if those could be quantified as a percentage of the median provider cash rate?
So thank you for your question. I can give it more in a percentage of Medicare because the cash rates, as I'm sorry, I think it was Dr. Friedman had mentioned, the cash rates can be so variable.
They vary by area.
So the percentage of Medicare, we are getting 100% to over 100% of Medicare reimbursements during our rate adjustments at Blue Shield Magellan.
How can we get that data by provider cash rate, not Medicare rate?
So I looked to my colleagues on my right to see if you guys have any suggestions on getting the cash rates.
When you say cash rates, you're talking about a provider in the community. If I'm a provider in the community, what do if I say I don't take insurance, this is what I charge, here's my cash rate?
Exactly. Insurers have that data by metropolitan statistical area. And so I'm wondering if we can get that response, perhaps not now, but later.
Good takeaway, Rob. Yeah. Yeah, I wouldn't have that data, but most providers probably post it on their website, or they'll tell you what their cash rate is.
Yes, insurers have that data.
Yeah, that's something we'd have to probably talk to our actuarials about, who track that kind of thing.
Yeah, it's a market data too.
Yeah.
We'll get you that data.
Thank you.
Okay.
Yeah, same with Blue Shield. We'll take that away and see what we could find.
Thank you.
Anything else, Ms. Oliveros?
No, thank you.
Very good. Mr. Perez.
Morning. I understand that different programs will have different copays, but can you provide an example of what a copay would be for in-office visit? And then also one of the telecoms or web chinguses?
So yeah, I think copays vary. They vary by contract, I guess. Every employer group or person negotiates a different arrangement. So I mean, I've seen people have like $5 copays or $20 copays, or it could be a percentage of the visit. But what I can
Let's say the state of California, because it's so big.
Sorry?
Let's say the state of California.
No, it's just so different for each person's health plan. But the other part of your question was for telehealth, and the telehealth copay rate is the same as a regular in-office visit rate. So if somebody's going to pay $5 copay for an office visit, they'll pay a $5 copay for their telehealth visit through Anthem's Live Health.
Okay, what about the state workers? I'm not a state worker, so I don't know what their copays are.
Yeah, our reimbursement for behavioral health is.
Identify yourself for the record, please.
I don't.
No, you're on, Rob. You need to identify yourself.
Oh, okay. Okay. Because of the
What's your name, sir? And who do you represent?
Pardon me?
Give us your name, Rob.
Oh. That's a tough one.
Okay,
I got that. Rob Honecker, Anthem Blue Cross.
There you go.
Because of the Mental Health Parity Act, the reimbursements for the behavioral health services will be consistent with your medical benefits. So, for example, you have a variable benefits within CalPERS, but primarily your office visit is $15. That will be your office visit for the mental health, and we extend that to the Live Health Online. Inpatient on a hospital is 100%. Your care program is 90%, and your choice is 80%. So, again, it's consistent with your other benefits.
And with us, with your Medicare population, an in-person appointment is a $10 copay. Your basic plan is a $15 copay in person, and telehealth is a $0 copay.
Thank you. And then, go ahead.
Yeah, so it is the same copay for in-office versus telehealth, so it's 10, 10, and 15 for the therapy visits.
Thank you. And you all addressed the difficulty of people being able to get appointments, and you, when people try to call in several times, they can't get an appointment. You elevate that call somehow. Is there a code word that the employee needs to use to get elevated, or is there a special phone number, or how do you guys track that?
So for Blue Shield Magellan, if an employee calls in and says that I have looked on your website, I've called providers, I can't get a hold of one, it actually gets escalated into our appointment search team. If they call in and say, I'm looking for providers, we will give them the option, would you like a list for you to call, or would you like for us to link you to our team to help you? And we get about 30% of people who want us to look for the appointment, and 70% want to start looking at their own, and I understand that. That's a really different type of relationship that they're going to have, so they want to do the interviewing of the psychiatrist or therapist.
So at Anthem, if a member is trying to find an appointment and they're having trouble finding it themselves, they can call the member services number, and they will they'll help facilitate giving the patient the names of providers who are within the geographic area. If they're still having trouble, then Anthem will take over that role and start calling the providers within that geographic area and seeing if they have availability to see the member with this condition, and then they'll facilitate that. If a member says, look, I'm calling 5 people, 10 people, and I can't get an appointment, but I found this one clinician and they're not in your network. Well, if we don't have an in-network provider available, then we will pay the out-of-network provider at the in-network rates.
Yeah, and so very similar to our system, there really is no code word per se, but when people call in, we present them with the various ways in which they can get treatment, which sometimes they don't even know they could do it right in their home if that's what they choose to do. So I think that's an important piece to bring up early in that conversation. We also do an assessment to make sure the person's not at risk or doesn't need something higher level at that moment. And then we give them that choice, right? Do they want to interview a few people? Do they want some names? Or do they want us to look for an appointment? But if they call a second time, we absolutely escalate that to our appointment search team. We have a dedicated team that just does that, and we will call the member back with that appointment.
So I didn't, maybe you guys said I didn't copy, or I didn't hear you. It's not tracked by like a medical record number. So if I just call in Joe Schmo, and then 2 days later I call in Joe Schmo, but I don't give you the whole backstory.
No, we'll see that you called immediately. We'll see that you called us a few days ago looking for an appointment, and we'll ask you, how did that go? And presumably, it didn't go well.
You would always be asked identifying information, and a record of that would be kept in the record log, and there'd be, so if somebody else took the call, they'd be able to continue that follow-up.
To the same extent that they would?
I think it's kind of standard practice, and we're all regulated by the Department of Managed Care, and these are pretty standard practices to document everything. And yes,
not the documentation, the escalation of the service.
Yes, it'll even get escalated to a licensed provider to understand the particular issues of the patient and try to match the best provider with that person.
So yes, we document everybody who calls in, and we even put in the providers that we've provided if we did send them a list, so that we can go through and understand if those providers were not responsive, we follow up with them on our network team as well.
Slick. Thank you all very much.
Thank you.
Thank you. Ms. Green-Ross.
So first I just wanted to thank the staff for responding to Controller Yee's request in August to hold these hearings so that we could dig in and understand the complexities and ensure that our funds beneficiaries are getting timely access to quality health care. And we have definitely heard how from all of you, and it sounds like you're all committed and passionate and trying to aggressively ensure parity for mental health access. We look at some of the national trends on legislation federally and across many states trying to ensure that pay parity is also out there. I know California's had some legislation last year, but given the complexities of the need to tap into these new innovative strategies to ensure access, especially in the rural areas, into telemedicine and the other networks, anticipating there will probably be some more efforts for legislation to ensure the quality of that care. And to that end, I hope where CalPERS can be helpful in hearing any of those legislative matters that might help improve access to care. That would be great going forward. And lastly, I just wanted to ask our new Health Benefits Director, Mr. Moltz, who shared with me some of the work that they're putting into as far as the customer survey enhancements and how they're working with collaborating with other state providers and how that will be integrated in our contracts going forward. And specifically done just because it sounded really important work. I thought you should share it with everybody, what you told me. And lastly, it is important to share it, but I, again, wanted to thank you all because I definitely heard your acute awareness of the compassion and concerns, particularly about young adults and focusing on children and veterans and the LGBTQ community. So on behalf of Controller, you very much appreciate your time and effort and continue with the good work on this. Thanks, Doc.
Sure.
Thank you.
Yeah, happy to share. And I mentioned this very briefly in our last meeting, but maybe add a little bit of detail. We've and this is prompted in part by the focus that the board has taken on mental health issues, but it's also just the right thing to do as well. We've been talking to Covered California, as I've mentioned, about a number of common priorities and identified mental health, improving the mental health care for all of our collective members as high priority for both of us. And as part of that, we're using it as sort of a test case to try to move forward with both entities at the same time to increase our influence with health plans across California. And as part of that, we've begun what I would describe as a listening tour with national experts. Dr. Logan and a number of the folks behind me have been on calls with staff from Covered California and national experts talking about handful of key issues, what the best practices for measuring plans, delivery of mental health services, quality of health care, of mental health care, access to mental health care, and a lot of the issues that surface today, integration with primary care, some of the challenges that can arise when you have what I describe as a carve-out situation where you have two separate legal entities providing mental health care on the one side and physical health care on the other. So we've had some very good conversations to date. We're planning on wrapping up those discussions. One other thing, sorry, which is how you use our contracts with health plans to drive some of those outcomes. So you identify the North Star, and then you look at how you use our contracts to get to the North Star in this space. So we're going to we have some other calls lined up over the next, I think, 6 weeks or so. Be wrapping up that part. In February, I think, is our goal, and then in the spring, we're going to be working together to try to come up with a common set of measures and next steps. The other part of this, of course, is decreasing the number of different messages that the plans are receiving from large purchasers in California, so that they're hearing, they're looking at the same things, we're asking the same questions, and then we're able to compare notes with one another on performance. So those are some of the things that we're doing internally that I think are going to be critical to making sure that we're doing the best we can in this space.
Thank you.
Thank you. Mr. Ruffino.
Thank you, Mr. Chair. Sorry for taking but two quick comments or questions, one about data and one about process. So with respect to process, do you think it's appropriate for patients with mental health conditions to be forced to make multiple phone calls, sometimes through unresponsive provider panels, to try to find care? And should patients struggling with depression, bipolar disorder, anxiety disorders be forced to go through this burden? Wouldn't it be easier to provide each patient with a scheduled appointment with a provider rather than forcing them to dial for care? Not sure, just asking. And the question about data, real quick, I'm not sure if you have a data system that allows it to track whether it's enrollees when they're referred to Beacon and Magellan or whatever for care, when they're referred, that do actually receive an appointment? Do you track that? Does the system or whatever system you have in place measure the elapsed wait time between the date when a patient is referred for mental health treatment and the date on which the patient actually receives treatment? Do you guys have a system that calculate the drop-off rate that indicates the number of patients who are referred to external provider networks but never get an appointment, or perhaps an appointment 60 days down the road? So what is the drop-off rate, and what are the elapsed time, the wait time, in each of your respective plan? I recognize that you may not have that right on your fingertips, but to President Jones' comment, perhaps if you come back to give us additional information, perhaps you can provide some of that data to better understand and get a better picture. Because ultimately, and I hate to quote it, but the LA Times yesterday, the public perception up there is, and I quote, I read you directly, is that the industry experts paint a more troubling picture of superficial gains that look good on paper, but do not translate into more effective and excessive care. And that's what we need to fight. That's what we need to prove. We need to disprove this perception out there that collectively, you as the provider, us, CalPERS, and everybody, that's what we're up against, and that's what we need to prove that they're wrong, that we're doing here. And I think we are trying, but we have to be more aggressive in showing that we are. Thank you, Mr. Chair.
Thank you. It's the end of our list. I do want to say before I ask you all to step back, thank you again for being here. Great presentation, great dialogue and discussion back and forth. We all know that this is an issue for all of us to deal with. It's not just the providers, it's not just our system, but it's society in general. I served on our local grand jury, and part of what we looked at was part of this issue. And we realized that our county had done away with their mental health program, and that falls to everyone. And then further studies showed that 30% of those in our local jail are there because of mental health issues. That's not where they need to be. So we need to, as a society, address these issues. And hopefully having this dialogue and having people on the web watching and listening, that we'll be able to get more people that are interested in this field, and it can help alleviate some of the problems that we have with not having enough providers. So again, I want to thank you all very much for being here. Great presentation. We do have some requests to speak from the audience, but I'll wait until after you've all taken a seat back, and we're going to take a 10-minute break for our court reporter. So we'll be back here at 11:10.
Thank you so much. Thank you.
Thank you.